she's looking at are environmental control for lights, TV, and a call system. In the context, we're starting in her home and then we can expand it. But right now we're going to look at just her home. So I think we can figure out referral because it's going to be pretty much the same group of people. For Shannon's particular assessment, who should be on the team?
Hey, Heather, can we pause for 1 second?
Sure.
I looked up, it stopped recording, so I just hit start again. Can you look on your screen and make sure?
Okay. Yeah, it's recording.
Okay.
All right.
I think we might have missed a little bit in between, but sorry.
Okay.
Keep going.
That's good. Thanks. Okay, so we've got physical therapists, OTs, PTs, SLPs, assistive technology professionals, vendors. Yeah, her parents for sure need to be involved. Doctor, Shannon, obviously. Yep. All right, guys, good. Okay. Okay, so what other information do we need about Shannon that we don't already have? Goals, plans, her future, what's the device going to be in her, where is the device going to be, what does her room look like, right, her ability to sequence with her head array, insurance coverage, good one. All right, and if it's going to cover environmental stuff. Her ability with the technology, how's it going to be set up, how's her house set up currently, everything she's currently using, wheelchair, the flexibility of the wheelchair, right? Parents' feelings about digital lights. Yeah, exactly, Charles. How many things do we need to be getting hooked up? Okay. All right, so a lot of good things here. Okay. So key needs. I think this one's pretty easy here. I'll throw this out. Okay, so yeah, environmental control at home, and specifically, yeah, independent control. Yeah, independence is huge, especially for her age. She's wanting to become more independent. And specifically, what did she say she wanted to control? Her TV, her lights. Well, she wants her door closed, but she doesn't. We don't necessarily have to have automatic. And George is saying if it's a control from her bed that she wants, then there will be. And where will the switch or device be mounted? Yep, that's a good one. Right, in a call system, right? So who can think of a one measurable goal for, let's do TV. All right, she'll be able to control the TV and light 9% of the time using her smartphone. I like that, using a smartphone. Okay, turning it off in a timely manner. Well, is that measurable? We need maybe within, like, have an actual specified time frame, maybe. Right, she can't use voice commands, but that's true. We can't use voice commands, but we can still turn off the TV, and we need a specific time frame to make it measurable. I guess Shannon will be able to independently turn on TV and change channel within 3-minute time frame. That's a good one. Michael, that's her voice, but it's her voice through AAC. So let's see, these are popping up so fast. Shannon will be able to independently control TV and light 9% of the time using AT, right, via AAC. AAC device. That's a good one. Yes, she already has an AAC device. And AAC devices have what built into them? Yep, Aldrich's has a good one. She'll be able to use her technology to turn on and off the television, change the channels by pressing buttons on an AAC device on her wheelchair within 90% accuracy. Good. Yeah, Aldrich, if you're a special education teacher, you better have this measurable goal thing down pat, right? Okay, so what are some key features of the assistive technology that we're thinking of for the environmental controls that she will need? Yeah, head array, so that maybe it's something that can be used with her current head array. How it will, yeah, mounting is a key feature. And will she be able to access it while she's in bed? That's going to be huge. Transmission method, very good, Raquel, because we just learned about all of the different types of environmental control transmission methods that are available. And if we're talking about TV, what's the transmission method that we're going to need for TV? Correct, infrared. Okay. AAC device that can be updated. Yep. Okay, so lots of good things here. I think we can figure out decision and documentation process. Again, going to be pretty much the same group of people. What might be needed for training and follow-up? A home visit, very good. Yes, we're going to need lots. Yeah, we're definitely going to need a home visit. Trials, parents need to be included in that. Yeah, actually, there was a study that was conducted that when parents and caregivers are involved in the training process, abandonment rate goes down immensely. Okay. Yeah, lots of training for environmental controls. Vendor installation is going to be a huge one, right? That's a very good point. Okay. Okay. All right. Anything else you can think of? Okay, so nothing around to interrupt the transmission. Good. Making sure it's properly installed. Will someone, right, somebody on her team knows how to fix it. Hopefully a caregiver should also be trained on how to fix it and troubleshoot when something's not working correctly. Okay. All right, all good items. Any questions or any other comments about Shannon before we move on to our last case study? Right, or who to call, right? when it's not working, not if it's not working, when it's not working, right? Because it's technology. Well, how to sleep comfortably with tech in your bed. Yeah, how about we don't sleep with tech in our bed? That's what I tell my kids all the time, get the phones out of your bed. Maintenance plan, that's a good one. All right, you guys have a lot of good feedback and comments and goals and everything else. Battery backup, oh, good one, Raquel. Any backup, really, right? Can she bring the device to her next home? Well, let's hope her next home is a college dorm and she can hopefully take it with her. Yep. Yep, all very good points. It's a lot, and when we do this as a group, it's interesting to see like how many different things that we really need to be thinking about, and why we really need to have a multidisciplinary team, because everybody has their own perspectives and their own expertise in that area that brings a different, group of, information to the table. Okay, all right. I think I'll be handing it over to Teresa now.
Okay. Yep. Can I pull it, the presenter?
Yeah. Might have to reshare, but.
Oh. What happened to my, oh, I see, because you were, sorry. So JD is our case, which is just go, okay. You can hear me and see me?
Yep.
So JD, they have, make sure I'm recording, okay. A young man in his late teens who has a spinal cord injury and a traumatic brain injury. Now what I don't understand, he uses a dependent wheelchair and is reliant on others to move from one location to another. He was in a power chair in the video. So I don't know if they're just saying that he's not consistent with it, but we'll keep going. His spinal cord injury is complete with sensory and motor loss. So way back to our first one. So that's in Asia A, and he is C4-5, leaving him with minimal shoulder movement. His problems are maintaining an upright trunk and head position as he fatigues during the day, difficulty controlling his power wheelchair with his right hand as his posture starts to compromise, loses the ability he needs to use his sip and puff control for computer access as his head moves into a more forward position. So I'm just trying to look at your question. So he does have a YouTube video channel. He seemed like a really fun kid. But looking at the video and looking at the summary, so he was in a power wheelchair. They're saying upright tolerance is compromised, which would be reasonable with that level of injury. And if he does fatigue during the day, then that would cause it. He looked like he was able to control his power chair pretty good in the minimal time we saw him, but I would expect that as his posture starts to compromise, controlling the chair would be difficult. And then the same thing is if his posture changes and he's not going to have the right setup, so sip and puff for computer access is not going to be in the right position. They also say skin discoloration over his coccyx. The discolored area never regains a healthy skin color even when he's out of his wheelchair for extended periods of time. JD and his mother have concerns that his seating system is no longer providing adequate support for him, especially when he fatigues. So with the hat model, the human would be the person with tetraplegia, so that would be JD. The activity that we are talking about is access to the wheelchair controls, head control throughout the day. We will talk about the assistive technology, and the context is when he's out of his bed to his wheelchair, he wants to use it in all his environments. Now, so Michael, I was going to ask you that they show him getting in a shower with a power wheelchair. I'm questioning his transfers. I guess what's confusing about this, and I've read this study several times, they really focus on him getting the home modifications and getting a shower chair. So when we get to some of the needs, we can weave that back in. But I think we'll have to think about his upright posture, his independent with power mobility, and then this pressure sore. Not that I'm giving you guys the answers, but the video felt a little inconsistent. So if you're thinking of all of these things, who is going to make the referral? Physical therapist, OT, doctor, PT. Yeah, it could be whoever is identifying. So if he goes into his family physician and saying, I'm having a hard time sitting upright, they may say, well, why don't you go to PT? PT may say, hey, I'm not an expert in seating. Why don't you go to the seating clinic? And so then you can bring the whole team into it. I want to go up. Let me just look at your questions. They show him getting in a shower with power mobility. I'm questioning his transfers in the shower seat with max assist. I'm guessing he would be dependently lifted into it. When he fatigues, does it mention his respiratory? It's a lower cervical, which partially controls his. You're right. So he could have fatigue if if he's not sitting up properly. He's not going to get the best expansion of his respiratory muscles. But the C4 starts getting into compromised the trunk for the and the diaphragm. So that definitely can be part of it. And was there another question? Okay. So we've listed a lot of people. Is there anybody besides who we've listed? So the OT, the PT, the physician, the patient, his mom, the ATP. Who is one team member that we have not listed here? And I'm going to talk about the vendor, heating mobility specialist. What about his skin? What team member might be coming in and help looking at his skin? Yeah, the nurse. So I definitely would make sure the nurse is part of it. So it could be wound care nurse from a clinic and or home health nurse. Nutrition is always super important with wound care. Also could be like a home health aide who makes more observation. Seems like mom is his primary care provider, which is common also if he doesn't have funding for an aide. So what information is needed? I've rambled a lot of different things here, but let's start going through the different domains. So sensory abilities. What do we need to know about his sensory? We said he's C4-5 complete. I think he has, he has no sensation, George. And the way they described it, so the way the pressure sores are, discolored area never regains a healthy skin color. So technically that's stage 1 if there's skin discoloration, but they don't name it. And yeah, circulation. So someone with a spinal cord injury is going to have some vascular instability. And so if he has no sensation and he has nothing below his level of injury and he's not able to do pressure relief, then he's really set up to be a high risk. So physical abilities, not being able to do a pressure relief would be one big physical ability. If what functions are currently, yes, but we're not, we don't want to get to the solution yet. We still want to go through the domains. So you're right that we want to go through the different features. So we'll pause on that one for a minute. Kareen, make sure we come right back to that, and I'll go through. I want to sort out recline, tilt, leg rest. So physical abilities would be his posture. It would be his access to his chair, repositioning, the whole interaction of him and his equipment. Cognitive, what we want to know about cognitive ability for him. It did say he had a brain injury. And yeah, he did look like he was pretty good. But we would want to make sure that he's safe, not only driving his power chair, but he's remembering seat functions. Yeah, and his memory of how far does he have to go back, what is his attention, exactly, sequencing. That's a big thing with really good pressure distribution. Language abilities, didn't seem to have any impairment with language. Positioning, where the technology will be used. So it's pretty much right now we're looking at in-home, but with his age and his goals, we need to be able to know that he's going to be able to use it in environments like appropriate for someone his age. Yeah, he did go to a hockey game, not just in-home. So social. I also, I definitely would look at in-home, but then looking at, okay, school or work, family activities, friends. And I did want to echo that Kareen does he have good concept of time, remembering to tilt every 30 minutes and determine length of time. Exactly. So that's where some of the behaviors can come in that maybe they only do a pressure relief like once an hour. So we talked about environment, social, cultural issues. So he Definitely had a social outlet. Didn't pick up on a ton of cultural. I know he said military was important to him, and some of his friends went off to military. But we would want to be aware of if there's any sensitivities to either using or accepting assisted technology. Yes, he was a football player. Psych as far as like acceptance, where he's at with his disability. Family issues. Mom seems super supportive. So we would maybe want to see what other family members are involved. And then past and current assisted technology use. So what does he have? If this is his first piece of equipment, maybe what is working, what is he comfortable with? And that's where I get into some of the programming, continuing to introduce new use of the existing equipment. And yeah, mom's ability to troubleshoot is definitely something that she seems like she's a good resource. So key needs. What do we want to focus on as a group? What would be his key needs? And then we'll pick a measurable goal. And then we'll get back to, I think, was it Kareem, the key features. What are his key needs? Pressure relief and positioning. Yep. Postural control, pressure relief. Yep. Pressure relief. Mobility. So mobility, pressure relief, positioning, energy conservation. So I'll put that with positioning. And then consistent access. Sip and puff, back up when he's heavily fatigued. Let me go up to okay. So yeah, Emily, we want to look at energy conservation. So if there's certain times during the day, and the other thing I think of energy conservation, if he knows he's going to the hockey game, then maybe he needs to adjust his morning routine so that he has the time in the evening. Sometimes I feel like we focus on starting the day and then spreading it out, knowing you're not going to have it at the end of the day. But I also like thinking reverse. And then I was going to say access. So yeah, to AT in all positions, and also access to getting out of the house. And then his position with sip and puff, I'm going to write that down. I'm making a little diagram here. And then Michael entertainment was the hockey and the backup. Okay. So I'm going to wait on the measurable goal. So what I would do is kind of break it down. So in the VA, you can get a primary and you can get a backup chair, but in the private sector, you can only get one. So we usually focus on using your insurance for the most expensive one, and we would proceed with the power chair. If we're being brought in right now and he has that power chair and we want to focus on the positioning, and therefore the positioning is going to help us address the pressure relief, and the positioning is going to help us address the energy conservation. Does that feel okay to everybody? So we are seeing him, he's rolling into our clinic and he's like, hey, I got this power chair, but here are the problems that I'm having. You know, I'm really having a hard time with my positioning because I fatigue, I fall forward. When I fall forward, I can't access my sip and puff, and then I can't do my computer use, and I also can't tolerate being up in it all day. So if we focus on that, what could be our measurable goal? I'm going to give you guys a minute to type because you guys have come up with some really good goals. For the current case, I'm saying yes, let's focus on, he already has a chair, and let's look at what we can do with the current chair that he has. We could always start perfect with the brand new chair, but it's very realistic that somebody has equipment and they're not maximizing their features, and they aren't using everything they have. So let's go through and confirm what features we think he should have in this chair. wound healing could be a goal. Let's talk about features. Which features are we assuming looking at the chair, I'm assuming he's going to have, you guys already mentioned tilt recline. Who was the one? Was it Kareem? I'm really bad with names. I'm going up. Yeah, Kareem. You had the tilt every 30 minutes. So what features? Head support, tilt, recline, head strap, good cushion, contoured back. Right. Okay, so Charles, he had, so if he doesn't have those, we could see if we could add them. But I would bet, based on my experience of seeing people coming in like this at clinic, they're given a chair with all the different features, but they've never been taught how to use them. So JD will be able to consistently provide pressure relief using tilt and recline independently on a prescribed schedule for RN, using his controls independently. I'd put a measure more than 80% of the time, or more than 95% of the time. It's always great to say 100, but sometimes I like to say more than 90%. That way, at least you're starting, and then you can increase it. Like you can first say 75%, and then go to 90%, and then go to 100%. Yeah, Lee, you're a good goal writer. And then that way you can go back and say, did we meet it? Demonstrate change of function to pressure relief every 30 minutes, 100% of the time. Yep. And you could also add in there, he demonstrates change of function for pressure relief every 30 minutes or 15-minute period, 100% of the time. So you can say he's not only doing a pressure relief, but he's staying in that position, and then he's coming back forward. Be able to use pressure relief on the schedule 3 out of 4 times, 75% of the time. Be able to use pressure relief on a schedule. And for the measurable, they really reinforce to us to define what that schedule is. And yes, we can say with assistance. So the important thing about the measurable goals is that we are defining something that we want to achieve in terms that we can go back and measure it. So when he comes in, I would look at his existing chair. If he didn't get if he didn't get a tilt and a recline, or let's say he only had tilt and we're realizing that he's not able to fully achieve pressure distribution with a tilt only, and then our goal would be to add recline. And the reason for adding the recline would be to fully achieve best pressure relief. Going through and making sure that the current chair he has isn't able to meet his needs, and then going back and you have the justification for why you're asking for something more. A lot of times people need programming or they need application of how to use it. And then someone mentioned ROHO, so you can have a goal just be to assess pressure distribution using pressure mapping system to understand peak pressures or high risk areas. You thought the text said that reclining increased pressure. It's probably, that's why it's best to use a tilt and a recline. That if you go back to the position paper on seat functions, that's a really powerful resource for me, because truly you need tilt and recline to get your maximal distribution. With a recline, you're going to have more risk of shearing, and depending on the property of the cushion that he has, he may or may not be benefiting from the recline feature because of the property of the cushion. So I think that looking at the property of the cushion and then how the cushion functions with the seat functions, and then how he's doing it, you know, with the combination of like with the schedule and the sequencing of the tilt and recline. So I'm looking back. Did they say you can make a goal to do pressure mapping? So for trial period, you can ensure the selections are appropriate. So typically, the pressure mapping is going to be a resource to help you interpret in an objective way what's going on at the seated surface. There are becoming products out that have it built into the cushions and to the mattresses, but that's not going to be part of the exam. And your goal could be to do pressure mapping just to get quantitative information about the seated surface. And then, yes, you would do that to get that objective information. Because you don't know, is he breaking down because of the recline? Is it more shear? And he's not breaking down, having the discoloration. Or is he having discoloration because maybe he's sweating and maybe there's moisture, or maybe he has some incontinence and there's, at that environment that it's wet? Or is it his bed? Is he fine when he's in his chair, but maybe we need to look at the mattress and the bed? So you can kind of do some deduction there. So we've made all these math suggestions. Who's making the final decision, and then who's finalizing the documentation and process? So ultimately, the physician is giving the final okay. And as you've said in the others, it's going to be the entire team, obviously the consumer. So JD and his mom need to agree with it, and they need to know this is going to fit into their lifestyle. They're able to do it. And then the clinicians and the supplier manufacturer are going to do the specifications of the equipment. So I look at the role of the supplier, and I'm in the private sector, it's going to be the supplier. In the VA, the supplier and manufacturer have a combined role. But in the service delivery guideline, the supplier is going to be responsible for the equipment, like speccing it out, coding it out. The clinician is responsible for functional application, and then the physician confirms and gives the final okay. So we've written our great letter of justification. Lee has done a great job with his storytelling, and he has convinced us that, or she has convinced us that he can get the equipment and it arrives. So now we have this chair. What are we going to do for training and follow-up? We have the features, we have tilt, we have recline, we have a cushion that we know works from the pressure mapping. We're going to set up a schedule. So yeah, we're going to look at the different features. So the vendor is going to help us and make sure that we have the programming set, that everything is fit, adjusted, integrated, that JD knows how to select the features. He's using it, having some performance. So the whole care team is going to make sure they get trained. And then what about follow up? Yep, charging, backup. So what I do in my clinic that is not always typical, I don't know if anyone else here is feasible, but after they implement it, we'll have them follow up, and depending on their need, if we leave and think, oh, they were really overwhelmed, I might do a 1 month follow up. Or if it is later, if they feel like they got it, I might do a 3 month follow up. What I love about the school systems, and I always caution this because I don't want to minimize, you guys do have a huge volume that you're responsible for in sometimes different buildings, but I love that you have the longitudinal access, that you have the teachers, and you have that check-in process. Some of the patients in the clinic, they just kind of disappear into a black hole, and I don't see them for 5 more years, and then they come in and their chair's completely falling apart. And if I could have followed them along and done more follow-up, I feel like I could have helped them with that gap from when they received it and then when the chair is falling apart. So routine scheduled follow-up to assure that the training is adequate and making sure that the wound care nurses are keeping us up to date on that his skin is not only not progressing in a negative direction, but it's getting better. Charles, the thing about calling the patients after 2 to 3 months is that has always been a historical good check-in. But what happens is if I have 50 patients, I need to check in, and then I'm sitting at my desk calling people. From a reimbursement standpoint, I can't bill for any of that time. So it's better if I can get them to come into the clinic and I can see them. And unless I'm in a scenario environment where I have preventative follow-up and I have maybe triggers that I might have not, like I might have support staff make the calls, and if there's a problem, then they pull us in. Chairs that respond to vocal commands, this would not be part of the test because this would be more advanced, but I have recently seen where they're taking some of the voice-activated switches and integrating them into the chairs for theory tilt. I'm starting to see some of that. But as far as driving it, no. Okay. So let's pause. What time is it? Oh, it's 8:39. I went over a little bit. Let's come back at 8:45 and we'll wrap it up. Sound good? Thank you, George. If you're still on, that's a great point, is trying to get them to be more responsible. Olga, yes, you'll have access to the case studies that we talked about. I'm just worried that there might have been one of the cases that didn't get recorded. But the videos you are open to. Stephanie, there's scenarios. So since I haven't seen the exam, I don't know if they have like case study and then 4 questions related to that one case study. I feel like they have vignettes, so maybe like a small vignette, and then there's like a question with 4 answers.
Yeah, that's how the exam, I know when I took it, was like that, where you'd have, yeah, kind of like a little mini case study of like, here's the information about your client and then questions related to that. So
they would only have one set of questions per little scenario.
yeah, well, yeah, like they would have several questions, but it would be, yeah, per scenario. It just helps put everything in context for answering the question. It actually made it a little bit easier to answer some of them. But that was a long time ago. So,
yeah, I took it a long time ago too.
I took it in like 1997. So.
Oh my God, so did I. We were probably together. I took it in Orlando. Where'd you take it?
Pittsburgh, University of Pittsburgh. Yeah, my graduate program actually paid for it.
Oh wow.
Yeah, they wanted to make sure that they were teaching to the point, you know.
Teaching you?
Yeah, make sure they were teaching us properly and we could pass the exam. So.
I can't remember. I think it was either after Med Trade or Resna. It was after one of those.
I think ours was after Resna.
Yeah.
I think we were doing ours at, yeah, right around the Resna time.
Stephanie, I don't know how long it takes. Like when you start your process to get your exam ID. Heather, do you know? Does it take 3 weeks?
Yeah, I don't know. I can't imagine it would take more than that.
Okay, 1 more minute. And then we'll funny. I'm so impatient. Like 3 weeks would feel like an eternity to me. But maybe it just gives you more time to practice. Okay, it's 8:45, so let's keep rolling. So the exam, it's you're allowed up to 4 hours to take it. You don't have to stay there the whole time if you finish early. There are 200 multiple choice questions. So I know throughout the course, some people have said, are they open-ended? Are they essay? No, it's all multiple choice. It's the same style questions as the practice exam, and we're going to go through some questions tonight. And you take it at a Prometric test center, and you receive the preliminary scores immediately. Heather and I were talking. I feel like I had to wait 6 weeks, and I got a packet in the mail. Do you remember that?
Yeah,
that was horrible.
Test center, and it was not electronic, and it was still filling the scan sheet.
I think you get an immediate score, and then it's not official because they have to go through and make sure that it's like validated. So the outline is on the Resna website that I'm sure you guys have seen. They say write your own questions. Think of a scenario that you could write to address and bullet point them under. Make sure you cover all ages, settings, and include all the domains. I feel like more people have done more kind of collaborating with, like, as far as problem solving and talking through what would be, because I think having another person kind of reflect back to you gives you that validation. But some of you have been really comprehensive in your resource utilization, and I think how you study best for yourself, that this may be a strategy that works for you. As far as test accommodation, George, they would honor whatever accommodations you need. I would just, when you're applying for it, just mention that at that time. And you guys can always use Charlie as a resource. You now have his email, and he is super responsive all times of day and weekends. So this is the biggest part. I think that, most people are out in the field. They're not in a test-taking mode. So I think that sometimes our anxiety about taking a test, we overthink things. So just take a deep breath and don't overthink the questions. Use your perspective that this is a generalist exam and it's not requiring expert training. So you're going to come, the ATP is a generalist. If you spend all day in seating and positioning, you're going to want to take your time to think about the sections that Heather went over. If you are comfortable with computer access, AAC, electronic ADLs, the different like infrared and all the different transmission levels, then you're going to want to spend time on the seating side. And that's generally where the camps of people are. So when you're preparing, get yourself that exposure to the area that you're less familiar with. When you're reading the questions, as we've been coaching you at the end of each session, go back and see, what are they asking me? So read the question, read the answers, and then you do your deduction. But go back and say, what are they asking you? And it's this inferring that sometimes we think too fast and read over the question.
Don't read between the lines. Just
would you say?
Don't read between the lines.
Yeah. And I don't know this, because I'm a very, I like the paper. So, you can't cross them out because it's on the computer, right, Heather? You have to in your head say it's not A, it's not B, and like, okay. So go through and make sure that there's always, well, let me keep going through. Eliminate the obvious one first. So there's always going to be an obvious incorrect answer. Oftentimes there's going to be two remaining. So compare and contrast the options with the keywords in the question. Make sure it relates to the actual question. So pay attention to the keywords such as except, all but the following, best, least, first. Olga, I'm gonna put you on the spot. She had a really good question about someone with multiple sclerosis, and she was saying, well, if the person with multiple sclerosis has endurance issues and also vision issues, well, which one do I pick? Because they have both. So her and I were talking through it, and my answer is, well, almost everybody with multiple sclerosis has endurance, but only some people might have vision. So if I had to pick between the two, I would go back and say, what are they asking me? And so maybe best or most common would be why I would pick something with endurance. Olga, did I paraphrase that okay for you? And Charles, you can cross out, even better. So go paying attention to those words, and we're going to practice this in a minute. Pay attention to qualifiers, so none or all or always or never. And so that's where you go back and what are they asking me? If two answers are essentially the same, assume that they're not correct. If two answers are completely opposite, one is definitely incorrect and one may be correct. So I think that's where you go through what are they asking me. The umbrella options that contain other options, and the scope of all options might be included in the correct one. Heather, can you help me give an example for this one? An umbrella option. I was having a hard time coming up with an example.
Yeah, I'm not sure.
We'll kind of come back to that when we go to the examples. But it's essentially that if you, if one of the options then splinters in like several, then the scope of what you're talking about may include the correct one. Use of longer options, not always the case, but it includes more specific discussion. And if a statement is more detailed or more specific, it might be correct. I feel like they've gotten a lot better because I took a test taking class, and it's really hard to write a good test question. And it's easy to, if you have like a 2-word answer or a 7-word answer, it's usually going to be the 7-word answer is correct. They really force us to make sure that all answers are easy or equal. But, you know, if you come through and you have one that's a really detailed and specific, that's usually going to be the right answer. And I don't think they do that. If you're not sure, pick C. I don't think that exists anymore. So let's go through some questions. We have 5 questions. So assistive technology used for reasonable accommodation of workers with disabilities frequently results in greater safety and higher productivity for workers without a disability. This is a good argument for. So this is a good argument for universal design, human factor engineering, the ADA, American Disabilities Act, matching person to the environment. Okay, what's the question? Let's go back. Assistive technology used for reasonable accommodation of workers. So I would underline that. Reasonable accommodation of workers with disability frequent results in greater safety and higher productivity for workers without a disability. So this is a good argument for. I don't have, so we have, this is where I don't know how to use the polls. We have an A, we have a B, we have a C. We have another A, another A. Okay. Let's say the answer is A. So let's say why it's not B and C. So the goal is it's reasonable accommodation of workers with disability results in greater safety and higher productivity for workers without disability. So it's Reasonable accommodation is not only helping people with disabilities, but it's helping people without disabilities. And that is the universal design, because universal design helps everybody. So it's not B because human factors engineering is specifically for a certain population. Right, Heather, the engineer? The ADA is saying that you have to have accommodation. And then matching person to the environment, we don't have a specific technology that we're talking about. So the ADA is a precursor for why we want universal design. So the best answer is that reasonable accommodation for workers with disabilities results in greater safety for everybody. And again, you guys are going to have to mark this because they don't have it. I don't think they have it marked on here. Yeah. Yeah. So A is the answer here. 2. Olga, let me see. If you need a reasonable accommodation, it would for a disability. Right, but they're saying that it's the reasonable accommodation helps everybody. Okay, 2. Even with careful evaluation, providing a backup plan or device is important because a secondary method of accomplishing a task is available if the first one fails. The primary device may be too complicated for the user to use effectively. The user will need time to get used to a new device, or the new device may not be allowed in the school. So even with careful eval, a backup plan or device is important. So why would a backup device or a backup plan or a backup device be important? A. I thought I saw a different one in there. C, yeah. A. Okay, so the answer is A. Yes, George, always have to have a plan B because the high tech will inevitably fail. So let's talk about why it's not C. So the person is going to need time to get used to a new device. And Heather, please jump in if you need to.
Yeah, so C basically is telling us that we're going to implement two new devices for this individual, which is something we definitely do not want to do because that learning curve then and the cognitive load of introducing two new devices for them to use. So even if, yeah, I mean, providing a backup plan or device, yeah, they're going to need time to use the new device, but we don't want them to have another device that they then also have to learn. That one, I mean, I can kind of see where you're coming from on that one, but that's not the reason we would have a backup plan because they're going to need time to use the new one. That's not the main reason in assistive technology that we would have a backup plan. So this is one of those ones where we need to look what's the best option. D, for example, I don't think anybody picked that one, but a new device may not be allowed in school or work environment. Well, it better be, right? There's some exceptions to that. Like you can't have like audio recording in a classroom because of privacy issues. But for the most part, devices are going to be allowed in those environments. If and B is not going to be correct either because if the primary device is too complicated for the user to use, it shouldn't have been selected to begin with. So that one, so B and C can be marked off immediately. And then the main reason that we always do a backup in assistive technology, because it is technology, is when the first one fails. It's not an if the first, I mean, I know it says if the first fails, it's when the first one fails. Because it is technology, we need to have a backup plan. Yeah, so that is the best option.
So Stephanie we always provide a low-tech version of the language set. Is that a good example of providing a backup plan?
Yes, yeah, usually AAC, there's always I mean, it's pretty rare when I don't see one that there's always like a low tech, just like communication version of their high tech with the symbol sets. That's a real easy one to have a backup plan for.
Okay. And then Michelle, I do agree that you are ruling out B, C, and D to come to your answer.
Mm-hmm.
So A is the correct answer on this one. 3, a 56-year-old with diabetes mellitus is referred to wheelchair assessment because she is having difficulty walking and has had several falls. The first thing the ATP should assess for is strength and fatigue, ability to use a motor wheelchair versus a scooter, impaired range of motion in the lower extremities, impaired sensation, and foot problems. So going back, and I'm pausing because you're really going to do all of them. So when you look at this, they give you the person with diabetes mellitus, so you're inherently thinking of what someone with diabetes may have. So they're coming for a wheelchair assessment because they've been walking and they've had several falls. So you know they're not a safe ambulator because they're having difficulty walking, and the diagnosis is a diabetes. So the first thing the ATP should assess for is we're a little bit all over the place here. So a lot of you are saying A and D, and that's where I went to, because I'm thinking of, well, I have to show why they're not a safe ambulator and why they're falling. So I want to look for strength and fatigue. The absolute best answer to the first thing that they should assess for is impaired sensation and foot problems. And so what the question is going for is that somebody with diabetes probably has peripheral neuropathy, and the peripheral neuropathy is why they probably are having difficulty walking and falling. So somebody with diabetes may have a 5 out of 5 muscle strength, but they're still going to be falling, and they're falling probably because of their impaired sensation and foot problems. So the reason why this D is the better answer is because of the diagnosis with diabetes. Are we qualified to make those assessments? I think defining what problems are, what they have on the feet. I'm looking to see if anyone else has any input. Aldrich, do you see how it's Z? Because when I first took it, I was leaning towards A. Adrienne, A, C, and D assess impairments. All are equally important and can be addressed by the PT. The ATP would likely do B. Right, and that's the thing, is you need to do all of these. So you need to see what is causing them to fall, what is their strength. Now I've ruled out they can't ambulate. Do they have the proper range of motion to sit in an upright position? And have I ruled out manual chairs? And now am I looking at a scooter or a power wheelchair? See if there's any more questions. So yeah, what I learned with this question is to pay attention to the diagnosis. And Michael, it is subjective without tools. And I mean, only within the scope of what we can address, or maybe we need more information from the physician. The fatigue has been hard to objectively measure when I'm trying to get power mobility. I've used like a pulse ox and trying to do respiratory, but fatigue, or I'll do trials and I'll do demonstrations. But I think the lesson on this one is just to really look at that, the diagnosis, and there's going to be things inherent to that, as opposed to if I said a spinal cord injury or a stroke, it's going to be more direct. Okay, 5. Which of the following is the most important consideration in evaluating a consumer's operational competence with an augmentative communication device? Knowledge of when to speak, use of strategies to handle communication breakdown. Did I skip 4?
Yeah, you did.
Sorry. Let's go back to 4. Which of the following measurements must be considered in order for a consumer in a wheelchair to enter and exit a van? Floor to top of head height, seat to top of head height, seat to floor, and turning radius. So back to the question, which of the following measurements must be considered in order for a consumer in a wheelchair to enter and exit a van? Looks like we have a lot of A's. And it is. It's A. So that one was easier. So enter and exit the van is the important one. If we want to say for driving, we may want to say seat to top of head, because you want to be able to have that visual field to look through you don't want to be too high, you're looking through that blue screen. Seat to floor height is probably going to be more for like getting underneath the steering wheel if you use a traditional steering wheel, and turning radius is just to get around in the car. Okay, now we're at number 5. Which of the following is most important consideration in evaluating a consumer's operational competence with an augmentative communication device? Knowledge of when to speak, use of strategies to handle communication breakdowns, mastery of basic language skills, ability to access the device efficiently and reliably. So which of the following is most important consideration in evaluating a consumer's operational competence with an augmentative communication? So they did a good job of teaching this, because they're all, we have 1 C. We have all D's in 1 C. Okay, I'm passing the baton to you. Why is it not C?
Okay, so A, B, and C are all language communication skills, but we're looking at their use of the consideration and evaluation, their use of the device. And in order to use the device, we need to look at their access ability and making sure that they can access it efficiently and reliably.
So right. Operational competence equals access.
Exactly. Yeah, so like Aldrich said, a communication breakdown is why we have the AAC device in the first place, which is basically A, B, and C, right? Right, so yeah, okay. Saying, yeah, operational competence and not language competence or language skills, okay? So those are the key terms right there, is the operational competence, which is being able to access a device and using it efficiently and reliably. And if you look, A, B, and C are all very similar. They're talking about language and communication skills, whereas D is completely different from those first 3. So that would be the correct one.
And then if I had no idea, because I'm a seating therapist, then I could try and batch them like she said. Knowledge of when to speak, use the strategies to handle communication. So try to see, these are all similar, and this is different, so it must be the one that's different.
Right.
Okay. So am I skipping? Because I feel like my handout has different questions. So we did housekeeping. It's really been, I tell you what, guys, I think Heather's really good. So I think you should give her kudos. Her and I, it's the first time we've taught together, and I want to be her assistant. So thanks, Beth. So really, you guys have been great. Thanks for muting yourselves. Thanks for all the interaction on the chat. You know what, I'm going to go back to the very beginning because I thought we had housekeeping at the end, but it's not. So remember, you're going to get an email from GoToTraining, and it's going to look like all the rest, but it's going to have a unique link to the post course. It's going to ask you to complete your assignment and pay attention to it because they can't replicate the code if you lose the email. You're going to get a post course wrap up from me as Charlie, and that'll be the course eval survey and the follow-up instructions. You'll get a one-time access to the practice exam. It's going to come about a week after the last class. And then once you receive that in the post-course assessment, you'll get your CEU. And you have access to all of this for 60 days. Heather, anything, any closing remarks?
I think everybody has all of our contact information, including Charlie's. So yeah, if you guys have any questions, obviously, we'll be able to kind of help. And if it's, you know, maybe specific about assistive technology, I think, you know, Teresa and I would be good ones. And if it's anything specific to the course or to the exam or anything on that respect, I think Charlie would be your best bet on those types of questions.
Okay. Well, we will stay on for about 5 minutes. It looks like you have 20 minutes of your evening back to you. For ATP related continuing ed, look at the NERTS website. I think theirs are like $20 each. And then also the, Heather, you're in Pittsburgh, the RSTCE, don't they have webinars?
Yes, they do. Yeah, you can go onto the University of Pittsburgh website, specifically look for Rehab Science and Technology department, and you'll be able to find, let me see if I can find it real quick. You can find their webinars.
Adrian, do you know when I say NERTS, do you know where to go for that? Okay. The other thing is there's oftentimes conference proceedings. I know ISS has done that a few times, where they'll pick select presentations that they record and then they'll replay them through that RSTCE. And you can go back and activate that and get the CEU for that specific session.
And I just threw up the link for the RSTC webinars. They're on demand.
Oh, perfect. Thank you.
Yeah, they do some live, but most of them are on demand, so you can just do them at your leisure. Also, actually, believe it or not, if you, depending on the type of CEUs you need, AbleNet actually does.
I was just thinking of that. Doesn't Toby too?
Yeah, they're totally free. And if you are able to attend, they've changed it a little bit, but if you can attend the live session, you will get CEUs for it. You used to be able to do the recorded ones, but they're switching it up. So in order to get CEUs, you have to attend it live, but they're free. And they do all kinds of different things. Michelle Lang, who's big in access, like mounting and seating positioning, switch access. She does a ton of them for them.
Trying to look up the ones for
Michael, contact Charlie about your hours and see if he can get that ball moving for you.
Teresa. Are you still on? Here is have to move my thing. So if you go to the NERTS, National Registry of Rehab Technology Suppliers, and then go to education, here are the webinars. Oh, some of these are 45. You can kind of play around here. You could also review articles. And the on-demand ones. Oh, they're all 45. I thought they were like $20. But looking at the different topics, they're all pretty good.
Yeah, and Resnas are pretty inexpensive too. Yeah. I think they're 35 is Resna, right?
Let's look. My little toolbar keeps getting in the way.
I think you have to go to the
Is it the archive?
Yeah. But I don't know if they give it to you right away or you have to look for it.
Oh, $32 for members and $45 for non-members. So that's cheaper than NERTS.
Mm-hmm. Michael has a question. Tracy, you might know the answer to his question about DMEs and billing.
Okay, wait. Michael, can a physician who owns his own DME, can he bill for my time with a patient? Okay, so the physician owns, like he's a vendor. Can he bill? No, because there has to be a separation of duty between the person that does the evaluation and the vendor kind of franchise. So the physician cannot bill, even though he's not doing it, you're doing it, there has to be a separation of duty. And that came about maybe 7-8 years ago, because vendors used to have therapists do the eval. Yeah, Michael, I would say no, because there has to be and you have to do an affidavit. The supplier has to do an affidavit to say there was no financial relationship with the person that did the evaluation to the person that's dispensing the equipment. So you would have to be like the ATP, and you'd have to have a therapist that did the formal vow. So Olga, please clarify who makes the final decision and finalizes the recommendation. So what Medicare will say is that there has to be a specialty eval. The physician can choose to do the specialty eval, or he or she can delegate it to the clinician. If it's delegated to the clinician, the physician has to sign off on their work. So I would say the final decision is the physician. My understanding, though, is that the exam is not reimbursement focused. So if the question is in wording of the clinical expert, so for some of the cases that we had clinical decision making. Fidel, in the U.S., if you're using funding, there has to be a separation of duty between the person doing the evaluation and the person dispensing it. So the supplier, as an ATP, has to maintain a separation. They can assist and collaborate and guide the clinician, but the clinician, you have to sign an affidavit saying there is no financial relationship between the clinician. Okay, any more questions?
We do have one, I'm not sure what he means by ECU. So are we going to take ECU test before the ATP exam? I'm not sure what ECU is referring to.
Olga, I would say from a clinical expertise, that the therapist would be the one to make the final recommendation compared to maybe the family or the patient. Like if they're making their decision on the clinical application of the equipment, then yes, I would say the therapist. So William, ATPs not associated with suppliers. ATPs can be clinicians and they can be suppliers. In the term of Medicare terminology, a supplier that dispenses a power wheelchair has to have ATP certification. But there's a lot of fluidly because like I'm an ATP, Heather's an ATP, but we don't work for suppliers. So just be mindful of the context of how it's being used and what their role is. Night, Olga. Okay. Any more questions? Either clinician or supplier. Yes. Okay, Heather, are we ready to close up?
I think so.
Okay, I'm going to stop recording. Night, everybody.